Thank you, and I'd like to thank the organisers for inviting me. It's a pleasure to be here. I have to give a confession to start with, though. As you see, 4P medicine, 2P speakers, and Peter Helling was clearly the first choice, and so they had to match the name, and so it limited the number of options for the second speaker. As I said, I'm going to focus on the lower airways, but clearly, there's close interactions and more considerations about the link as we move towards systemic therapies with biologics. First, disclosures. I'm involved with a number of companies that are involved with biologics. I also have an educational employment with GSK as a global medical expert on a part-time basis, but I'm here in my academic role, and all the opinions I give are my own. Now, thinking about the journey we've gone on with medicines in asthma, we've considered asthma to be a single condition and given everybody the same treatment, normally inhaled corticosteroids, and they're very effective in many patients. But we recognize that when we're thinking about disease control, that there are a proportion of patients who have inadequate disease control, some severely so, individuals with severe asthma. And we've had to change our thinking about management of the disease with the advent of biologics, which are expensive therapies, and one doesn't want to give those to everybody and just see who responds. You want to be able to predict who are likely to respond to get the right treatment to the right individuals. And this has depended upon having a better understanding of the disease and to try and identify predictive biomarkers that will help you select those individuals. So I thought I would just walk through some of the history behind this and show how it's developed. And in terms of precision medicine, I'd be thinking about predictive biomarkers that help us select those patients, but also thinking about how we can use these treatments as preventative treatments to prevent future risks, because that's one of the important aspects of disease management in asthma, is preventing disease exacerbation. And so I've used that as an outcome measure to illustrate how the precision has improved. Historically, the first biologic was anti-IgE therapy with omalizumab, and that was selected on the basis of clinical phenotyping, whether someone was atopic or non-atopic, did they have a raised total IgE or not. And it was confined to individuals with allergic disease because we recognize that allergen drives a Th2 response, giving rise to the generation of cytokines such as IL-4 and IL-13 that drive the B-cell isotype switching to IgE production. And IgE binds to high-affinity IgE receptors on mast cells, dendritic cells, and also to lower affinity IgE receptors on a number of other cell types that are all considered to be of relevance as far as asthma is concerned. So if one can neutralize that IgE, the hope was that it would lead to clinical disease improvement. And it did indeed. So this is pooled data from many studies showing that those individuals in placebo-controlled studies had a 38% reduction in exacerbations when they were treated with omalizumab compared to the control group. What was apparent, however, was that selecting patients based on being atopic or having a total IgE was not necessarily a predictive response biomarker. There was some evidence that individuals below 75 total IgE didn't have a significant reduction in exacerbations. The license actually goes down to 37. But as you move up through increasing levels of IgE, the magnitude of difference in reduction in exacerbations compared to the control group does not show a substantial increase. So an individual with a very high IgE may be a responder or a non-responder. So you can't predict from that which individuals are going to do best. And indeed, in a number of published studies with omalizumab compared to placebo, you can see about 60% of individuals report benefit with omalizumab. But in these studies, you can also see that in the placebo groups, there's about a 30 to 40% reporting good improvement. So that treatment is only producing about a 20 to 30% improvement over and above placebo. And it's difficult to predict, and so clearly there are going to be individuals that are not responding, and so there had to be developed a stopping rule whereby you made a clear decision fairly early on in the treatment whether you were going to continue with that treatment or not. So to try and identify whether there were better biomarkers that could define which patients were going to be responders, other aspects of the biology were looked at. IL-13, released from Th2 cells, upregulates an enzyme in the airway epithelium called inducible nitric oxide synthase, which gives rise to an increased generation of nitric oxide within the airways, which can be measured in exhaled breath as the fraction of exhaled nitric oxide. IL-13 also upregulates within the airway epithelium genes that are IL-13 responsive genes, such as CLCA1, SERPIN-B2, and periostin. Now, periostin seems to be generated by the basal cells, and so it has been considered that one might be able to measure the level of periostin in serum as an indirect marker of that IL-13 response within the epithelium. And we recognize that IL-5 generated from Th2 cells promotes eosinophil generation. And so eosinophils could be used as another biomarker either in blood or in sputum. And so in a prospective study, placebo-controlled study with omalizumab, it was looked to see how these different biomarkers could be used to identify patients more likely to respond. And we can see if you look at periostin or eosinophils, cutoff levels were determined from the study, identified that if you had a periostin above 50 or peripheral blood eosinophils above 260, you were likely to have about a 30% reduction in exacerbation. And that was statistically different from those individuals that had biomarker levels below those levels. Exhaled nitric oxide came out as being the biomarker that identified those individuals that had the greatest response. There is some concern there from the point of view that also exhaled nitric oxide, which normally goes down with inhaled steroids, has also been shown to be a good predictive marker of poor compliance with steroid therapy. And so it may be that some of these individuals were benefiting from omalizumab and expensive therapy because they weren't compliant with their standard medication. So thinking about phenotypes, the situation moved on to try and consider more about the inflammatory phenotype within the airways, and could that be used to better characterize patients, particularly with the advent of newer biologics that were coming along that targeted inflammation. And using induced sputum, it's apparent that you can divide patients into one of four inflammatory phenotypes. They can either have an increase in eosinophils, an increase in neutrophils, an increase in both neutrophils and eosinophils, what's called mixed cellular disease, or compared to health, have no increase in neutrophils and no increase in eosinophils, paucicellular. And one can see that if one adds different layers of complexity into this, as has been done in this study, which is a topological data analysis, integrating clinical data, inflammatory data, biological data, physiological data, one begins to see the heterogeneity of severe asthma. In this study, there was a group of healthy individuals that clustered together and a group of milder individuals that clustered together. Each dot here, or a larger dot, represents an individual patient or a collection of patients. And the color code represents the level of disease control, as reflected by the asthma control questionnaire score. Normally, a level of 1 or low is good control, above 1.5 is poor control. So we can see the red, orange are individuals with asthma control questionnaire scores of 3, 4, and 5, extremely poor control. And the rest of these individuals here, in this illustration here, are all patients with severe asthma. And the topological data analysis, based on all the data that's put in, cluster those into different groups. So we have one group here that is predominantly neutrophilic airways disease based on sputum neutrophils and has severe airflow obstruction. But we have another group up here that also is neutrophilic with severe airflow obstruction. And so clinically, those two groups of patients would be considered to be the same. But the topological data analysis, based on all the other information it has available, separates out those two groups. So clearly, if you're going to intervene in neutrophilic disease, you would need to be able to biomark those different groups, because otherwise, if you mix them together, the disease pathophysiology may be different and you may get different outcomes. In the middle here, we have a group here that is eosinophilic with high serum periostin, high exhaled nitric oxide. We have another group here that is very similar, but this also has upper airways disease with nasal polyposis and is aspirin sensitive. So the cluster separates those out, although the biology is similar. And we have another group here with sinonasal disease, more anxiety and depression. And so it's apparent from this that if you're going to target a specific biological process, you need to be able to have biomarkers that help you identify those individuals. And I'm going to focus on the eosinophilic patients because that's where the major developments have been as far as the neurobiologics are concerned. We recognize that there is a close relationship between the severity of eosinophilic inflammation within the airways and the level of interleukin-5. Now, I mentioned before that in the normal pathway for IL-5 production through the Th2 cells, an allergen-driven pathway, but we recognize that this is normally a very steroid-responsive pathway, and so it doesn't explain why these individuals with severe asthma still have IL-5 and eosinophils within their airways. And we now recognize an alternative pathway for IL-5 generation through a cell population called ILC2 cells, innate lymphocyte 2 cells. And these are driven by non-allergen pathways. They're driven by epithelial damage that gives rise to the release of alarmins, such as TSLP, IL-33, IL-25. And this pathway, non-allergen pathway, is a very much less steroid-responsive pathway. And I'm not going to talk about it today, but the developments now are in neurobiologics that target these alarmins, such as TSLP and IL-33, to see if they can have a broader impact than the more specific biologics. And we see evidence for the overexpression of these ILC2 cells in this study with flow cytometry, looking at ILC2, IL-5 positive cells in mild asthma and severe asthma, where there's a substantial increase in these cells in sputum. And if we look at severe eosinophilic asthma, we find that IL-5 is significantly elevated compared to that in health. So steroids are not controlling this process in these individuals. And I've been part of a big European Union consortium called EuBioPred, which is trying to look at the biology of patients with severe asthma and to try and identify predictive biomarkers that can help better phenotype or indeed endotype patients. And using sputum transcriptomes of the sputum cell pellets, the BioPred study found 3 transcriptome-associated clusters labeled TAC1, TAC2, and TAC3. And TAC1 was associated with an expansion of genes that are linked to ILC2 cells. So again, further confirmation for the relevance of these cell population in severe asthma. And these ILC2 TAC1 population was associated with a much higher sputum eosinophil count than TAC2 or TAC3, and also a higher blood eosinophil count than TAC2 or TAC3. So this was an eosinophilic phenotype. But what's interesting from this is that exhaled nitric oxide, which has been linked to type 2 disease, did not differentiate any of these 3 clusters. And we know normally exhaled nitric oxide would be regulated by steroids. INOS is a very steroid-responsive enzyme. And so exhaled nitric oxide is not telling us about events that are going on within the airways in relationship to eosinophilic inflammation. The relationship between blood eosinophils and sputum can be readily explained through interleukin-5. It's a systemic signaling molecule that signals to the bone marrow and promotes the maturation and development of eosinophil progenitor cells, enhancing their state of activation and prolonging their survival. And so it'd be associated with an increase in the number of eosinophils within the circulation. And as I mentioned, that IL-5 that's driving that may be of allergic or non-allergic origin. It doesn't differentiate. So there have been a number of studies looking to identify whether blood eosinophils or other biomarkers could reflect events within the airways and that could thus be used as a surrogate biomarker that would help you select patients. And this is one such study that looked at blood eosinophils, exhaled nitric oxide, and serum periostin in relationship to whether they predicted sputum eosinophilia, with the ROC curves showing closer to this line the greater the sensitivity, and the closer here the greater the specificity. And one can see that blood eosinophils came out as the most sensitive and specific biomarker. Here's exhaled nitric oxide, and here's serum periostin. And this study had a replication cohort which reproduced the findings. So with the newer biologics that have been targeting eosinophilic disease, we have 3 currently. There's mepolizumab and reslizumab, which are monoclonal antibodies against interleukin-5 itself, and in binding to interleukin-5 prevents it binding to the IL-5 receptor alpha on eosinophils and leading to the eosinophil maturation and activation. And there's a third monoclonal antibody, benralizumab, which targets the IL-5 receptor alpha itself, and in binding to the IL-5 receptor alpha induces an antigen-dependent cell cytotoxicity and apoptosis of eosinophils and the almost complete depletion of eosinophils. Now, the most well-studied biologic of these in terms of the understanding of the biomarkers that might help you identify patients was with mepolizumab. And a first big study entered patients with a number of criteria. They could come in with a sputum eosinophil count of 3% or more, a blood eosinophil count of 300 cells per more, or an exhaled nitric oxide level of 50 parts per billion or more within the last year. The study was a positive one. It showed that mepolizumab reduced exacerbations compared to placebo. So it was possible to go back and look at, say, identify which was the best predictive biomarker that identified patients most likely to respond, to try and narrow down the population that you would give the treatment to. And what was surprising from this study was that sputum eosinophils did not predict a response. And up until that stage, eosinophilic disease had been defined based on whether you had sputum eosinophils or not. But individuals who came into this study with 3% or more did no better than those individuals who came in with 3% or less. And what was surprising also was that the best predictive biomarker of a response, with about a 50% reduction in exacerbations, were those individuals coming in with a blood eosinophil count of 150 or greater. So that was a simple biomarker that could be utilized. And perhaps the explanation of why the blood is a better biomarker than the sputum is that sputum tells us about events that are going on in the larger central airways. And that's where a lot of the inhaled therapy deposits. But we recognize that in asthma, particularly severe asthma, there's extensive disease throughout the airways, and that therapy may not be adequately reaching that part of the airways. And there may also, as we know, disease within the upper airways, and in severe asthma, sinonasal disease is particularly common. And so through the systemic signaling from these other sites, the blood eosinophils may be a better integrated biomarker of events that are going on throughout the airways, whereas sputum is a good biomarker of what's happening within the central airways. Another thing that came out of this study was the appreciation that the level of eosinophilia was a predictive marker of the likelihood of response and the magnitude of response. That the more eosinophilic the individuals were that came into the study, the bigger the difference between those receiving placebo and those receiving active treatment. So not only were eosinophils, blood eosinophils, a marker that might help you select those patients, but they were a predictive biomarker of the magnitude of likely response. And so in subsequent studies, blood eosinophils have been used as the biomarker to define an eosinophilic phenotype. And so in subsequent studies with mepolizumab, patients have come in with either 150 cells per microliter on entry or 300 in the last year. And you can see it reproduced the relationship between increasing eosinophil disease and the response. So we move from those who come in above 150 in this study, who had a 53% reduction compared to those on placebo, to a 61% if you take only those who come in above 300, and those 400 or more, 68% reduction, and those with 500 or more, a 73% reduction. So the more eosinophilic you are, the greater the magnitude of response. And the other monoclonals that came forward took advantage of this information and selected just a single eosinophil criteria for their entry selection, with benralizumab using individuals coming in at 300 cells or greater, and reslizumab 400 cells or greater. So we see here a 61% and a 68% reduction. So if we look at outcomes with those two biologics, we see that when you come in at 400 cells per mole with reslizumab, a 54% reduction. With benralizumab, 300 cells per mole, we see more variable results in the two key registration studies. And again, this is raising some interest from the point of view that benralizumab is a more effective depleter of eosinophils than those that target just the IL-5. And I'm not going to go into it today, but we're now appreciating that there may be more than one eosinophil population, with an inflammatory population and a resident population that may have different functions, and that the resident one may be involved in innate immunity. So clearly, IL-5 is a very key signaling molecule involved with eosinophils and is reflected by blood eosinophils, and biologics that target that influence that outcome. IL-13, as I showed you, was linked to periostin and exhaled nitric oxide, and there have been biologics that target IL-13 in severe asthma. And lebrikizumab is one of those. And in this study, they divided patients retrospectively on serum periostin and found those with a high serum periostin had a bigger improvement in lung function compared to placebo. than those with a low periostin, which did not differentiate it. And in this study, there was a very low exacerbation rate, and periostin didn't differentiate that, but exhaled nitric oxide did. However, a range of anti-IL-13 monoclonal antibodies that have been tried have now all been discontinued because, although they improved lung function, they had very little or inconsistent impact on disease exacerbation, so they didn't prevent future risk. That a number of therapies have been tried against IL-4 individually, monoclonals, and again, they haven't progressed. If we're talking about precision medicine, the history of the investigation of monoclonal antibodies against IL-17 in severe asthma is an example of how not to do or unprecision medicine. They didn't select any particular group, just gave it to everybody and found it didn't work. But they may well be individuals that have high IL-17, and if they were particularly targeted, one might have seen a different outcome. Of the other ones, the other one with the most potential is dupilumab, which is actually a monoclonal antibody against IL-4 receptor alpha that's involved in the signaling of both IL-4 and IL-13. But dupilumab is slightly bucking the trend in precision medicine, in that it's suggesting that you don't need to phenotype patients, you can give it to everybody. But when one looks at the data, it's clearly more effective in those with eosinophilic disease, and it may well not separate out from the other anti-eosinophil therapies with time, but we have to wait and see from that point of view. So in terms of the journey, we're very limited in asthma at the moment. All we have is defining whether someone is an atopic phenotype or not, or whether someone is eosinophilic using peripheral blood eosinophils. That we're moving more towards trying to identify endotypes, and as part of the UBioPred study, we'll be focusing on that with a large omic platform approach to try and understand the disease better, but there'll be a lot of complexities before you get any simplicity out of that. So if I just think where we're moving towards and the future of precision medicine in severe asthma, I think we'll be moving towards combination biomarkers, that single biomarkers themselves, certainly with eosinophils, are helping, but we may well need multiple biomarkers to try and narrow down those patients and particularly get specific endotypes. It doesn't necessarily have to be complex biology. There can be simple interactions between biology and clinical phenotypes, such as this data from the DREAM study with mepolizumab, which then looked at exacerbation reduction in those individuals who are eosinophilic, depending upon whether they had nasal polyps declared or not. And what you can see that those individuals that were eosinophilic and had nasal polyps at baseline had a much greater reduction in exacerbation compared to placebo, with about a 70 to 80% reduction in exacerbation compared to the 50% reduction in those individuals who are eosinophilic without polyps. So a simple clinical assessment there can help you identify patients who are going to be greater responders. We will see additional approaches to try and understand better biomarkers. Biomarkers have to be clinically utilizable. So induced sputum has told us a lot about the airways disease, but is not practical in terms of everyday clinical practice. So the emphasis now is not only on blood, but breathomics, and looking with mass spectrometry in the breath and volatile organic compounds as to what can be measured. And there may be, I think, a realistic hope there that there may be measures there that can help us understand the altered microbiome within the lower airways, and if so, could also be applied to try and understand the microbiome within the upper airways. Also looking at urine, urinary metabolomics, and this is some data again from the Wessex severe asthma cohort, taking mild asthmatic patients and severe asthmatic patients and looking at the urinary metabolomic profile, and that clearly differentiates and significantly differentiates out those with severe asthma compared to those with mild asthma. Whether this can then be taken forward to try and identify specific phenotypes that can then be used clinically to identify responders or non-responders to different treatment will be another step forward. And of course, thinking about integrating all measures in precision medicine, there will be the integration of genomics, particularly if one's thinking about future risk. This study looked at genetic polymorphism in asthma, in severe asthma, and found that the more polymorphisms you had in the Th1 pathway, the poorer your lung function, and the more likely you were in the purple to have severe asthma. So clearly, if you could identify those individuals early and be more aggressive in the treatment, potentially introduce biologics early, you may well get a better outcome. So we are on a pathway with precision medicine in severe asthma, and with the biologics, which will influence both upper and lower airways, we need to see a much better integration of the outcomes at both sites with these therapies. Thank you.
So do we have any questions from the audience?